Hello everyone, I'm Lorenzo Canziani. I'm a medical doctor and a PhD student based in Verona, Italy. I'm going to present the latest results from our group. Latent transition analysis shows improvement of long COVID symptoms over time and analysis of the orchestra cohort. I have no conflict of interest with the team. It's has been funded by the European Horizon 2020 program. These results are, at the time of this recording, under peer review. The study is part of the Orchestra project, which is connecting European cores to increase common and effective response to SARS-CoV-2 pandemic. You can visit our website for additional info and for our data portal, a platform designed for data sharing and reuse of data. We are now open to collaborations. Orchestra includes different work packages for cohorts, method and analysis, and vertical processes. The results that I'm presenting you today are part of the VP2, COVID-19 course and long-term sequelae, and VP8, statistical analysis modeling. So starting from the WHO definition of long COVID, here you can see the main characteristic of the study design of our prospective cohort study. Exposure of this cohort is SARS-CoV-2 infection in older population, patient with follow-up at 6, 12, 18, and 24 months. The infection with a clinical evaluation at each time point. Symptoms that could not be explained by an alternate diagnosis were considered long COVID, with a wide range of symptoms, including the ECRF. And at each follow-up, quality of life was measured through validated questionnaire, ESF 36 in our case. Cluster of symptoms has been widely studied and also reported by our group in another article. But the main point of this presentation is that the time course nature of symptoms is particularly tricky. We all know that symptoms can fluctuate, relapse, or persist, but this aspect is rarely explored because of limitation in study designs or in the analysis. And for this study, we included in the analysis all the time points performed. These slides represent the baseline characteristic of the cohort. More than 5,000 patients were actively included, with more than 9,000 clinical evaluations performed during the follow-up. Nearly two-thirds of the patients were from France and one-third from Italy. Nearly half of the patients were enrolled during the first wave. 25% of the patients were not hospitalized. 20% were hospitalized in an ICU. Only 11% of the patients were vaccinated before the infection. And median age is about 55, with a skew for male sex. Nearly one-third of the patients received corticosteroids, and other treatments were more rare. On the right, you can see the pattern of the follow-up. And it is important to underline that the 24-month follow-up was added afterwards, and because of this, many patients could not be included. Here you can find the main raw results regarding the unexpected symptoms on the left and the quality of life on the right. In the last endpoint, even if there are fewer patients included, symptoms are less frequent. So we applied the latent transition analysis to identify states of long COVID using a fully connected intent Markov model, allowing for transition between all pairs of latent states without imposing any a priori structure on the symptoms of trials or progression paths. The model identified 7 states based on the most frequent and important unexplained symptoms, this part, and quality of life measurements. On the right, you can see our interpretation for each state. The first 2 represent the acute phase, and then were used by the algorithm just for the acute infection. Healthy is a state with low probability of symptom, higher quality of life. Neurosensorial is with neurosensorial symptoms, isolated. Respiratory, long COVID, is a bit more nuanced in differences, but the main point is that it's the high risk of dyspnea. While for state 6, it has diffuse systemic symptoms, but no neurosensorial involvement, and was labeled fatigue in COVID, while the last state involves all the domains with the lowest quality of life and was labeled severe symptoms. Here's the distribution of the states over time. You can see that during acute phase, most of the cases were labeled as acute. And then from month 6 onwards, the percentage of healthy increase over time, and the respiratory state decreases. On the right, you can see the most frequent trajectories of the states. And the most important point to underline is that once the patient reach the healthy state, they do not change states anymore. And nearly 30% of patients reach healthy state. It is important to understand that transition probabilities are bound to several risk factors that are included in the model. On the left, you can see on the left, sorry, you can see how several variables, including age, sex, weight, and severity of COVID-19 are all changing the transition probability, which is represented by this space. For example, if a patient is female, the probability moves on the left. And in this case, moving on the left represents having a higher probability of post-COVID, and being on the right, a higher probability of being healthy. And on the left, you can see how 3 examples of patient-level risk factors, their conditioned initial probability of state and the conditioned transition probability. As the main point of our model is that patients who enter the healthy state don't change state anymore, we try to predict the probability of recovery based on filtering for relevant risk factors. On the left, you can see the probability of being in healthy state over time, considering 3 different cases, while on the right, the expected recovery times from long COVID to healthy states. So it can vary widely from nearly 20 months in case of May in the first wave to nearly 90 months for females over the age of 60. Clearly, this study has some limitation. The population is skewed toward patients hospitalized during the first wave, and only 10% were vaccinated. Follow-up compliance was lower than expected, and most importantly, this study does not try to identify biological mechanisms of long COVID. Briefly, the study has a solid design that includes quality of life measures and a prolonged follow-up time that reached 24 months. The algorithm that we developed is not built on prior assumption on long COVID and identified no relevant risk factors. Moreover, it included both continuous and categorical data, and it is able to manage incomplete cases and missing values. The main results from this study is the identification of resolution of long COVID, a common outcome even for patients